Okay, so good afternoon. So today we discussed cardiac disease in pregnancy. A very important topic equally in obstetrics and gynecology. Just like any other medical conditions complicating pregnancy. Remember, we are just from discussing anemia in pregnancy. We will later discuss sickle cell disease in pregnancy. At some point, we discuss diabetes mellitus in pregnancy and many other medical conditions that will complicate pregnancy because they are either pre-existing or their diagnosis is made within the course of the pregnancy or indeed postnatal. So, what will be our outline for today's presentation? Number one, we will look at classification of cardiac disease in pregnancy. Thereafter, we will narrow down on what is known as biventricular heart failure. Because almost always, cardiac disease will culminate after decompensation into heart failure. So, you really need to have biventricular heart failure at the back of your mind at all times. Meaning, you are looking for it, you are seeing whether it is on its way or whether it has occurred. Then, number three, we'll look at the New York Heart Association. Very important parameter for us in obstetrics. It might no longer be a parameter for my colleague physicians now, but for us we still find this very useful. Number four, after that, we will go straight into management. And in this management, we'll look at preconception, then we'll look at antenatal or antepartum, and then intrapartum. Very important. This is the most important part. I will even put a star, and then postpartum. So basically, that will be our outline. Suffice to mention that under biventricular heart failure, we'll look at definition, we'll look at the types, we'll look at symptoms and signs, we'll look at differential diagnosis in a nutshell, we'll equally look at management, but in general. My lecture duration is limited by 1 hour, so I will postpone most of the writing to a point where we will write notes. Dr. Sonjoy Chuluba says he will talk to me nicely to write notes, so that this will just be explanation, and then when I have time I can sit down, pen to paper, and write thorough notes. But this is just an overview, just to be at the same stage. Okay, having mentioned that, I will start. Classification. We all know that cardiac disease is normally divided into congenital and acquired. And under congenital, we also have two arms. We have cyanotic and acyanotic. But the flip side of this is that this cyanotic issue can be uncorrected or indeed corrected. Meaning somebody has done something about it, or not done something about it. And this lady grows, gets married, conceives with an uncorrected problem from childhood, or it was worked on. And that will have ramifications in your approach to management. Now, what are the acyanotic conditions? We know them. I will not mention all of them, but because this is an overview. But the most common one is ASD, which is atroceptor defects. And if you remember something about atroceptor defects, they are quite common, especially in a condition known as trisomy 21, Down syndrome, and docution. Cardiac ASDs are quite common, but we will not talk about that. Remember the septum primum, the septum secundum, before the formation of the fossa ovalis, but that takes you a bit in embryology to see how these defects come about. Then we have a ventricular septal defect. You know, this one is equally common, and we know that it's one of the components of tetralogy of Fallot. And what do we remember about VSD? It is a pansystolic murmur, almost similar to what you find in micro regurgitation. And other than that, we have another condition known as the PDA, which is patent ductus arteriosus. In fact, sometimes we even like calling it persistent. Yeah, anyway, you can call it patent ductus arteriosus. So, what do we remember about PDA? I'm happy Dr. Mzonda is a pediatrician. There. Yeah. We find what is called the machinery murmur, or a continuous murmur. So, I don't want to go much in this because this is basically pediatrics. Now, let's go to cyanotic ones, where the baby is even cyanosed. Child is cyanosed. What could cause that? Top on the list, of course, we know is tetralogy of Fallot. And we know in tetralogy of Fallot we have 4 defects. We have some kind of pulmonary stenosis. We also have a ventricular septal defect. We also have right ventricular hypertrophy. And what is the 4th one? Overriding aorta. If there's tetralogy, is there pentalogy of Fallot? I don't know. Then, what do you remember about tetralogy of Fallot? Remember, if you did an X-ray, you find that the lungs will be oligemic because there's less blood supply to the lung tissue. It's a boot-shaped heart. And you can go further and see how you manage tetralogy of Fallot. Know that the biggest problem you have in tetralogy of Fallot is the pulmonary stenosis, because there tends to be spasms at the infundibular aspect of the pulmonary trunk. And that explains the Tate spells. The baby walks, squats. Does a baby walk? What's the difference between a baby and a toddler? I don't know. But no wonder you give propranolol, you give intranasal fentanyl, and things that would dilate that part of it. Probably that's the biggest issue. And no wonder, other than open heart surgery, people would go for what? For shunt operations like the modified Braloff-Tausig operation, where you just manipulate those blood vessels from the blood vessels. Okay, away from that. The other one we know is a condition known as total anomalous pulmonary hypertrophic venous return. Very big term, huh? Truncus arteriosus. I don't know if, but again, the correct word is persistent truncus arteriosus, because truncus arteriosus is an embryological structure. Remember, the heart comes from several structures: the sinus venosus, there's the truncus arteriosus, and then we have the bulbus cordis. And then, anyway, they're not in embryology. Which other one do you remember? The transposition of the great vessels. You can include Eisenmenger's syndrome. and many other conditions that can lead to cyanotic issues. Okay, leave that for pediatrics. Let's go to what applies to an adult. Acquired. So under acquired, the common issues we have is hypertension. Because remember, in hypertension, there's too much pressure. And the blood is hitting all the corners of the heart. So what will happen next? The left side has higher pressure. So it will be left ventricular hypertrophy. And after left ventricular hypertrophy, what will happen? The chambers will just dilate, and then the valves will separate. Then the ventricular heart failure. So that whole series of problems known as hypertensive heart disease. But all that can be explained by the standing laws that I was talking about. In terms of fiber length and the preload and stuff like that. So we have hypertension. Which other one is the culprit? We have fluid overload. We are just giving fluids unnecessarily. Which other problem can we have? We have endocrine problems, right? Like thyrotoxicosis. It can lead to arrhythmias, it can lead to heart failure. What else? We know anemia. So when you have anemia and it's uncorrected or the patient decompensates, you end up with a cardiac problem. The other thing is the infection. Now, infection is in two parts. Remember, you can have what is called co-pulmonale. Something like that. So this is right-sided heart failure, which is secondary to a chronic lung problem. So somebody has got chronic bronchitis, emphysema, pneumonia, name them. Then later on it leads to the right side of the heart failing. And then later on, when the right heart fails, the left heart will also fail. So co-pulmonale. But also don't forget, we have our good rheumatic heart disease. Again, this is a sequence of problems. From a simple sore throat between the age of 5 and 15, we don't treat it, it graduates to rheumatic fever. And in rheumatic fever, we have the Jones criterion, which has got majors and minors. Carditis, we have migratory polyarthritis, Sydenham's chorea, also known as St. Vitus dance. And then we also have subcutaneous nodules, and then we have the minors. But you know, if you miss that rheumatic fever, then it graduates into rheumatic heart disease to damage most likely the left-sided valves of the heart, and that's rheumatic heart disease. So it arises from infection to some extent. No wonder we give what is called the secondary prophylaxis. Remember, patients are on benzathine penicillin? Or I don't know what they do in pediatrics. Then from infection, we also don't need to forget another common cause of that, which is cardiomyopathies. And which are the cardiomyopathies? The ones I remember are three. Hypertrophic obstructive cardiomyopathy, there is the dilated cardiomyopathy, and restrictive cardiomyopathy. So, again, cardiomyopathy seems to be a problem which is not well understood. However, we know that there are some associations. Like for instance, if you look at dilated cardiomyopathy, there is the association with Coxsackie B virus infection, or with the, I'm not a physician, back to him. Next, we have arrhythmias. So the problem is with the conduction. So we know that arrhythmias can also be problematic because the heart is not beating well. So somebody has Parkinson-White, Cannon-Levine syndrome. No, they have got these kinds of paroxysmal tachycardia, atrial flutter. There are such type of things. But those can damage the heart eventually, and you will have cardiac disease. Yes. So the list is relatively endless, but I feel these are the common causes of heart failure. Why am I mentioning that? You cannot give a diagnosis of biventricular heart failure and you end there. Heart failure is not a diagnosis. it has to be secondary to something, or precipitated by something, or exacerbated by something. You can't have a diagnosis of anemia. Where still I've seen with my own 2 eyes where somebody makes a diagnosis of very severe disease. Plan. For senior to see. I've never seen that such type of academic indiscipline. Okay, so these are several acquired causes of cardiac disease. No, don't move. Okay, yeah, you can now go. Okay, so now let me go to biventricular heart failure. This is number 2. Thank you, Dr. Kasson, the second on call. Now, please, get to know that terminologies have changed. The old name was CCF, congestive cardiac failure. I've heard also of congestive heart failure. That issue of congestive is not correct in terms of its description. So now the correct term is biventricular heart failure. So let's look at biventricular heart failure in terms of definition. So in terms of definition, biventricular heart failure is defined as a clinical syndrome so it's a series of issues of cardiac, 2 things, structure or function. So the problem can be with the actual structure of the heart, or it can be with its function, meaning the structure is normal, but the problem is with its electrical conductivity. Or it could be just the structure as an issue, the muscles, the valves, and other things. Do you remember the chorda tendinae? The trabecula? So you need to go inside the heart and let's see what really makes the heart and what can be wrong with the structure. Now, whatever this is, whether it's structure or function, it leads to the inability of the heart to either fill or pump blood at a rate commensurate with the requirements of metabolizing tissues. Because whatever this blood is supposed to reach metabolizing tissues. So the rate at which it should be receiving, the rates should be proportional to the feeding and the pumping action of the blood, which speaks to the structure and the function. So basically that's the definition of biventricular heart failure. It's a clinical syndrome of either cardiac structure or function which leads to the inability of the heart to either pump or fill with blood at a rate commensurate with the requirements of the metabolizing tissues. Types. So when you look at the types of heart failure, one of them is the right versus left. Why is this important? It is important because it talks about the clinical presentation. Remember, on the right side, we have swelling, or basically edema, bit of the lower limbs or the whole body, which is an asaka. We have abdominal distension, mostly because of ascites. We also have distended neck veins. So these are features of right failure. Left, we have easy fatigability. We have palpitations, exertional dyspnea. So somebody walks and they start feeling like they are breathless, shortness of breath at exertion. Whereas easy fatigability is just getting tired easily. Palpitations, you know what they are. Then there will be worse forms of dyspnea, such as orthopnea, where somebody cannot lie flat, and what is called paroxysmal nocturnal dyspnea, where they wake up at night to catch a breath. So, but also don't forget there is also a cough, which is usually at night, so it's nocturnal. So, if somebody has such things, then it's left. But if you have a combination of both, then it becomes biventricular. Both ventricles are failed. So you see why right-sided and left-sided failure is important, because it speaks to the clinical presentation. Obviously, I've talked more about the symptoms. Now I'm even forced to go to the signs, so that I would have also handled this. What are the types? What are the signs? When you have somebody with heart failure, what do you rush to do first? Of course, it's the vitals, right? Maybe to even give you an idea of what has caused it. Because if there is, let's say, radio delay, or there is a irregular kind of pulse, or other forms, be it pulses paradoxus, pulses alternans, and all these funny things, they can tell you that this most likely is a functional problem. It could be an arrhythmia. So other than vitals, what else? We normally check for the JVP. And we know how to calculate the JVP using two rulers and the positioning. What else? We check for the heart sounds. And you can have all kinds of abdominal heart sounds. Either we have added sounds, like S3, S4, or you can have murmurs. And again, murmurs, we know we have got different types. They could be systolic, they could be diastolic. Systolic even has got grades, the first one being the consultant mom. And then we have, consultant like Dr. Mandama John. Him is the only one who can, with a Littmann stethoscope, not like this type of stethoscope as we use. The proper Littmann is able to get the first grade. And of course, there are also special types of mamas like the Graham Steele mama and other names given, Austin Flint mama, and so on and so forth. Then don't also forget that you can have all those other findings at cardiac examination. What do you call that? You put your heart. Heaves and thrills. I've never heard them. Okay, heaves and thrills. That's right. I thought it's the name of a novel. Yes. So you see, you have to do. Then of course you need to check for the hepatomegaly, tender hepatomegaly, the liver, the spleen, and also whether there is ascites, whether you do a fluid thrill or you do a shifting downwards, whatever. I just wanted to remind you to say you have to examine the patient thoroughly when you have a cardiac patient. Okay, this was just right and left. It's okay. I'll get it. This is just right and left. I can now go. What about the second classification? The second classification will be systolic versus diastolic. This classification for heart failure is important for management. You know, the problem could be with the pumping or feeding. So if the problem is with feeding, the heart cannot just accept the venous return. Then that's the diastolic dysfunction. If the problem is with pumping, then it's a systolic dysfunction. And that's why here you need an echocardiography. particularly to look at what's called the ejection fraction. Ejection fraction can't be 100%. It's normal to have. Ejection fraction is how much blood is pumped out from the left ventricle at each cardiac cycle. So meaning that some blood should obviously remain and a certain percentage will go up. Now, if the problem is with systolic dysfunction, what drugs do you give? In addition to furosemide, you've seen we have given enalapril. I think it's 2.5, a low dose, meaning you're not treating hypertension as per se. Then we are also giving digoxin. Digoxin, you can give maybe 0.125 milligram. All these are once a day. What else do we add? We add a drug called carvedilol, which is, what's the dose? 3.125 milligram. What else? Spironolactone. What's the dosage? Very low dose, 25 milligram once a day. Then, if you so wish, additional. So these 4 drugs, how many are they? 1, 2, 3, 4. They are useful for systolic dysfunction. You don't give it as if it's across the board. No wonder for you to be very objective with your management, you need to have an echo first and see. Why do we give these drugs? We give these drugs because they are based on evidence. There's what's called the RAILS trial, the Radiance trial, which were done, which showed that if you give these drugs, then the risk of recurrence of the heart failure is reduced. Otherwise, you will just give furosemide. Those days would even add the slow K 600 milligram. Why were we putting slow K? Because furosemide, which is a loop diuretic, will cause hypokalemia, and you want to replace it with potassium by giving slow K. But it's not necessary because you can see these drugs are potassium sparing. Then you can also probably consider low dose aspirin. But don't forget, you have to deal with the problem. What if the problem is infection? I think definitely you will consider, an antibiotic. Yeah. I forgot to include under infection, infective endocarditis. Remember we talked about copper rheumatic heart disease. We needed to talk about infective endocarditis. And what is the criteria we use for infective endocarditis? Is it also John?
Dukes.
It's the Dukes criteria. Do we still remember the majors and the minors? We'll revise. But otherwise, let me talk about it. Infective endocarditis, our majors, we just look at 2 things: blood culture and echo. So in echo, we talk about things like vegetations, dehiscence of prosthetic valves, and basically issues of new mammals. But for the blood culture, we look at typical organisms. So which are the typical organisms? Viridans. Streptococcus viridans. That is the one which is a culprit for subacute infective endocarditis. But we also have what are called the HACEK organisms. Do we remember what HACEK stands for? We're in right? Okay, but we need to know. So basically that is it. I think it's common in pediatrics, infective endocarditis. You have to give that child antibiotics for a good number of and also for these dental procedures where we prescribe antibiotics and people don't take them seriously because the toothache has stopped. Tell them that you can end up with infective endocarditis. So please, all the time when we do something to clients, let's explain the importance. A child comes with a sore throat and you prescribe phenoxymethylpenicillin and you don't tell the parents the importance of those antibiotics, they'll end up with rheumatic heart disease. And they will require to go to heart hospital there for valve replacement. So just a small error of judgment can lead to a bigger problem in the future. So always emphasize the importance. Okay, away from systolic versus diastolic, we are moving. We go to another classification which is the, I won't talk much about it, which is the high output versus low output. Or if you want, you can call it forward versus backward failure. This one is important for what? For physiology. Because we really want to know, like for instance, in thyrotoxicosis, why is there heart failure? What's the link, you know, and so on and so forth. So you might need to know that. I won't talk about it. And the last one is where you say acute versus chronic failure. And this one is important for prognosis. Because if somebody has chronic heart failure, then they'll be on treatment for life. They stop the drugs, they'll come back to the hospital. And that is one of the fears I have with hypertensive clients, because if they don't take their drugs very well, instead of just taking another 5 milligrams once a day, they'll end up with a barrage of medications for them to live a normal life. Okay, so types, we are done. Symptoms and signs, we are done. Differential diagnosis. What can look like heart failure when in fact it's not? Now, one of the things we know, let me start with something basic, is the protein energy malnutrition. Again, we are lucky we have a pediatrician in our midst. She can confirm that patients with QASH tends to have an asaka. Why? Because they're not getting enough proteins. And if you don't get enough proteins, what happens? You have less amino acids. If you have less amino acids, what will happen? You have less albumin. After the liver processes those amino acids. If you have less albumin, what will happen? What will happen is that if this is a blood vessel, this is a cell. This is the intravascular space. Intravascular. This is the interstitial. And this is intracellular. It takes us back to body compartments. Now, away from the lecture from physiology, there's a lot we can discuss here. In terms of even the Stirling laws again, they will come back. Or forces, not laws, but forces. Now, what happens is we have a chemical known as albumin. Do you know how albumin works? Albumin is a big molecule which can't pass through the capillary walls, the simple squamous epithelium. It's too big. Why is it big? It's big because, so this is albumin. Let me even shade it. Albumin. Shade it. Albumin. So what will happen is that albumin is strategically in blood so that it reduces the amount of water molecules. So here water molecules only have 2 dots or 3, but there will be more water in the interstitial space. So what will happen? By osmosis, water will naturally move from where to where? It will be from a region of high concentration to a region of low. So water will be going in this direction. And what do we call that pressure it exerts? It's called oncotic pressure. Now, if you have the other way around, there's less albumin here. There will be more water in the blood vessel and less in interstitial fluid. Water will move in the opposite direction. And that will lead to what? To edema. That's why if you've got a child with nephrotic syndrome, you don't need to give them furosemide. That is very wrong. Just give them albumin infusion. Do we have albumin infusion like that? Even 20% or 5%? If you were to give albumin infusion in nephrotic, you're going to be surprised how the child will, within 24 hours, the child, all that edema will disappear. Because all you need is the albumin, for instance. But in this case, we are talking about protein energy malnutrition because somebody is not just getting enough proteins. Okay. And let me conclude by saying this is the principle which is also behind the use of colloids. If you have a patient who is in shock and you bled, you don't need to give them normal saline, which will even just cause hyperchloremic metabolic acidosis. You don't need to give them crystalloids. Give them colloids. Colloids are big molecules, like for instance dextran or starch or even hemacin. When you give it, this will be like albumin. So they will start squeezing water from the interstitial space into the intravascular space. Your blood pressure will rise almost immediately. No wonder they call them plasma expanders, because they are increasing the plasma. And they will stay in the vascular space for a longer period than the crystals. It's taking us back to basic science. Basic science is important. Okay, other than protein and energy malnutrition, you can have what's called protein losing enteropathy. It could be that you're taking enough proteins, but then you are losing it through GI, like you have celiac disease, Crohn's disease, ulcerative colitis, all these inflammatory bowel diseases. Or it could be that it is a liver problem. So liver pathology are many. It could be cirrhosis, or it could be something else. Or it could be a kidney problem. Why kidney? Because you are losing proteins like through nephrotic syndrome or chronic kidney disease or glomerulonephritis and this stuff like that. So you need to think of these differentials whenever you have somebody with heart failure. Don't rush to just see anyone with Anasaka to say, what if it's even preeclampsia? Me as a midwife, I can tell you this could be eclampsia. So always think widely and rule out other diagnoses before you narrow down. But obviously, having taken a history and examination, you cannot miss. Management in general, I think I've talked about a few drugs. Let me just say something, with your permission, to say management in general, other than the drugs I've talked about, and this is important for the nurses and midwives, is nursing care. What nursing care do we give to somebody who has biventricular heart failure? So I always tell nursing students to say where there are more marks for the GNC standard is what is called the nursing care plan. And you can't come up with a nursing care plan without knowing the condition. Because now they'll be talking about very relevant things, the students. You know, we open nearby windows, we'll do oral hygiene, we'll do this and that. You have to speak in line with the condition which has been presented to you. So what nursing care, and which even you, the clinicians, should write in the file. Number one, we say nurse propped up at 45 degrees. What else? O2 whenever required, maybe by nasal prongs. What else does the nurse need to do? You have to catheterize the patient. Why do we catheterize the patient? It's for two reasons. One is because you put the patient on diuresis. Now, this is a patient who has got easy fatigability. So their nursing rationale would be, I'm catheterizing because this is a patient with easy fatigability and exertional dyspnea. So I don't want them to be moving up and down because it will make them feel even more uncomfortable. Okay? So that is part of the reason. It's because of the symptoms. But at the same time, it's because of diuresis, because you are putting fusemide, so they'll be passing water too frequently. So you also, diuresis is basically because of the symptoms, or it will worsen the symptoms. But at the same time, it's for input, output. Because I don't think if it's hypertension which causes the heart failure, it will just go for the heart. But it also go for the kidneys. Yes, so you want to know the input output. That's the reason why we categorize. What else? The nurse should do what is called the daily weights. You can't just look at a person and say, you look better today. You are very greaters. You need to have objective numbers by doing what's called daily weights. So there must be a chart. Next, diet. Here you restrict fluids. Don't just give IV fluids unnecessarily. And you also restrict salts. What else do we do as a nurse? Monitor vitals. And SpO2. What else? They need to also counsel the patient on need for bed rest. Basically, I would say counseling, because you find that all the patients have gone to sunbath. Then you've got heart failure. They tell you, no, you can't go because you've told you not to move unnecessarily. So they need to be counseled. And also the counseling should also talk about drug compliance, because if the patient just feels better because we've given some furosemide and the edema has gone, do you know what will happen? Do you think they'll take the medication at all? Then they'll come back after 1 month, very dementors again. So that kind of counseling is important for you as a nurse, for instance, or as a midwife. So I've given a bit of nursing care, because sometimes we tend to just look at one-sided, just the drugs and you go. But you also need to add the nursing care protocol as well. I think my discussion would be incomplete if I did not look at the investigations. There are very few investigations that we do for heart failure, as we know. We've mentioned or highlighted some of them already. I think we know that ECG is important, because if the problem is an arrhythmia, why should you go for echo? You need to do an ECG so that you read the waves and be able to tell, and then know which drugs to give. I don't know if the physicians here remember what's known as the Vaughan-Williams classification of antiarrhythmic drugs. Has got 1A, 1B, 1C, then 2, 3. The last class is to do with the calcium channel blockers of the non-dihydropyridine type, like diltiazem and verapamil. Yeah, we have other drugs like Sotaro and amiodarone, and I don't want to go into that classification. But ECG is important. And what else? But again, ECG we have got two types. Remember, there's this ECG where you just go and do. Then there's also what's called a 24-hour ambulatory ECG. Because somebody could be having paroxysmal tachycardias. The time they go to radiology, the arrhythmia has gone. It will come out very normal. But the patient is insisting that, no, me, I don't feel well. I have palpitations. So how best can you capture them? By doing a 24-hour. I don't know how it is done. Or what's the other name for the 24-hour?
It's a Holter ECG.
Holter ECG. Holter. H-O-L-T-R. Yeah, and then we have echocardiography. We can also do, of course, what are called cardiac enzymes. Should I ask you which enzymes? This guy is the troponins, right? But if we still remember what happens to the troponins, where do they come from? They're part of the contractile elements. Remember there was troponin T, troponin C, and troponin I? Is that troponin I? I don't want to go into the physiology of cardiac. What happens to tropomyosin, troponin complex, and also the myosin acting binding issues, and also see how they differ in cardiac, smooth, and skeletal muscle. Anyway, cardiac enzymes are very important, especially if you are going to look at what is called the myocardial infarction. CKMB, things like that. Next, we can also consider, even the echo. There are two types of echo. I know most of them we do, but you can go through the esophagus, you can even go through as if the way you insert a nasogastric too. Okay. Away from this, we also have baseline investigations. Remember? Then there's also what's called cardiac catheterization. I don't know how many of you want to do intervention or radiology, but this is one of the other options. But the others obviously are things like full blood counts. You can do kidney function, thyroid function tests, etc., depending on what they're dealing with. With the permission of Dr. Chidowa Songiro, can I go to obstetrics and midwife? Because I'll conclude now with management. I will skip preconception, I will skip antepartum, I will go straight to interpartum. The reason why I've skipped these two is because they are similar to what we discussed when we look at diabetes mellitus. Also quite similar when we discuss sickle cell disease. Because all these medical conditions, the story starts at preconception. And that begs the issue of New York Heart Association. So in conclusion, what you need to do is, if somebody is a non-cardiac patient, you need to determine their New York Heart Association. They should be New York Heart 1 all the time. Number 2, we need to determine the cardiac lesion they have and make sure that we've optimized that lady before she conceives. Why? It's because pregnancy, especially maximum 28 weeks gestation, that's when you have maximal cardiac physiology, and that's where most of them decompensate. So, if they already were New York Heart 2, they were already in heart failure by the time they were conceiving, I'm telling you, that pregnancy is not going anywhere. It can take both that developing embryo or fetus together with the mother, together, both of them. And sometimes that's why we have been unfair to these couples, because they are married, they are happy, you know, I even attend most of those weddings. Because I'm a marriage counselor. No, all the ones I cancelled, the marriages are failed. The point is, you find the situation where you don't cancel them, then they conceive. No, to carry a baby is a very precious thing. They have reached 26 weeks and you just come. This is New York Heart 4. This is condition is very dangerous. So we cannot even allow you to conceive. You have to terminate the pregnancy. Do you think they'll easily accept? They'll say, no, just leave us alone. Just leave us alone. And you will see that heart condition will take its natural course. And you end up with a poor maternal and fetal outcome. So I mentioned this because of the importance of preconception management. Equally, the importance of communication between the pediatricians who could have picked the tetralogy of Fallot at the age of 1, to the physicians who will see most of this young lady as she outgrows the pediatrician's hands. Most of them will still want to be seen in pediatrics. Imagine somebody is 20 years, I know I want my doctor. Dr. Musonda who saw me when I was young. She's my aunt. You see? So they will be the only adults in a pediatric one. You see, but then there must be that transition to obs and gyne, where now us who are the midwives take over them and see them at preconception before they conceive and tell them that now you are ready, you can conceive. Okay. Other than the New York Heart and knowing the lesion, what else is important? Before I go to interpartum management, which is now the last part of my presentation, is there are certain conditions which are not compatible with pregnancy. Meaning that if a lady has that, don't even conceive until our good cardiac surgeons work on the condition and then come back to us. But don't even conceive. So before Dr. Mdani or Ziwa or Dr. Mtema at Heart Hospital sees and you have diagnosed that, tell them, go to those doctors. Those are doctors who even put on glasses. Then they work on the patient for 8 hours, they're operating. Then after they recover, they give us our client, and then we allow them to conceive. Ours is simple, just to allow the salad. What are those conditions? Number 1, Marfan syndrome. Marfan's syndrome with the significant dilation of the aortic roots. I don't want to talk about Marfan syndrome because it can be anything, Marfan. Very high heart palates, there are a lot of things, but it can affect the heart. The other one is the microstenosis. Again, we need to look at the size of the aortic, of the mitral valve in terms of its diameter. But really, microstenosis is lethal. The other one is the Mulenga syndrome. The other one is the aortic stenosis. Aortic stenosis is also quite lethal, though not as bad as microstenosis. But all these, I don't want to go in the details. You need to look at the diameter of the valve area for you to know that this can be allowed or not. So there are not so many, but provided they are corrected, then you can allow or disallow. Now let me go to intrapartum management. And here I'll be a bit slow because this is what makes your delivery plan. So if I say like we have a client right now, we are just from doing a major one round. That lady, we are saying that we will manage her as cardiac disease. So how are we going to write the delivery plan? There must be the name. So here we can put the name, Dr. Nani Chitalo. No, say it back to say no. Let me put my initials. Yes. Then we should put it female, maybe 89. Foul 1124/25. Diagnosis, we say micro regurgitation, maybe secondary to rheumatic heart disease, in brackets uncorrected. Then New York Heart Association 1. What else? Mode of delivery will be by induction of labor at maybe 38/40. Meaning this is mode plus timing of delivery. Then we write there fem. We don't have fems there. But we would have write, okay, let's say we have units, so maybe fem, my old fem B. Then we will write consultants or the head of the firm, we put there. Who's our consultant? Dr. Kasson, head of firm. Second one, go in brackets. Very clear. So you need to write those details. And what ink should you use? Red. Very clearly. And it should be on that paper? Front page of the file. Now, let's ask ourselves, what are we going to write now in the main document? The first thing is we are going to say, number 1, once labor established, right? Meaning, I don't know how that labor will be established because it can be spontaneous, it can be induced. But once you think labor is established, then you write first stage. How are you going to manage the first stage of labor, which is from diagnosis of labor to full cervical dilatation? The first thing that you are going to say is transfer patient to high dependence unit. You can't manage cardiac disease in an ordinary labor ward. Clear? Next, IV access. Well, you can even put 16G or even 18G. Then you repeat. What are we going to repeat? Maybe FBC, then group and save. What did we say? Catheterize the bladder. What else? We are going to O2. You can, if you want, you can say 5 liters per minute by nasal prongs PRN. Meaning oxygen, if you want to hear, you can just say oxygen to be available. Meaning if it's a cylinder, here we are very advanced. All our oxygen is piped. So you just insert oxygen whenever it's necessary. Next, propped up on cardiac bed with what? With table. How many of you have seen a cardiac table? Então, espera ver você cardiac table. Now, where you normally like writing notes from, that's not for you. That's for the patient. No wonder those tables are designed like this, so that they can be moved towards the patient. So the patient can be reading a newspaper. Okay, so what's happening in the country? Okay. Then you bring them some pizza, they are eating. They are not making any movement. Now, this is a cardiac patient, they put the food there. What will happen? She will be forced to move and sit. Now you understand why it's called the cardiac table. Yes, but you find on the cardiac table, that's where people put flowers, get well soon, cards. These other people are writing notes, putting grip stands. So that is meant for the patient. You can adjust it to get to the patient whenever she wants to. Clear? Next, we are going to say that next now, as part of this, you are going to give ceftriaxone, maybe 1 gram IV stat. So ceftriaxone has to be given in first stage. Why? Because everything that you will do, be it vaginal examination or what and what, can be a needles of infection, which will now go and sit on the valves and lead to infective endocarditis. So you have to be sure that you are doing things in a sterile, but you can give this for prophylaxis. Next, adequate pain or pain management. So you can go for epidural, but the problem with epidural is that you need to be cognizant of the blood pressures. For me, I would not be comfortable somebody using epidural in cardiac if they are not experienced. Here you need an anesthesiologist who can be able to manipulate the blood pressure. Otherwise, there are some conditions like aortic stenosis that purely depends on the preload. You drop the BP, sudden death. It can be that bad. So, epidural is one option, but again, don't forget that you can still use pethidine or fentanyl if the cervix is less than 7 centimeters and contractions are moderate or strong. So don't allow the cardiac patient to be in pain, because if she's in pain, she will activate the sympathetics, and that will release now the stress hormone. And the whole issue becomes now just a vicious circle. So adequate pain management. Next, it will be monitoring. So what are we going to monitor? Vitals, SpO2, input, output. So it has to be very clear. No wonder you need to be in high dependence unit. Not any alone that remember one. We need a dedicated midwife there or nurse to be there, monitoring and writing in appropriate charts. Next, restrict IV fluids. Meaning, don't give IV fluids, please. Where you just wake up and say, no, let me even put the Kalingas here. What is this fluid doing? Doctor, it's just a plain fluid. Why are you giving a plain fluid? Doctor, you know, okay, sometimes it's important. You know, and that's good fluid. Do you know that you can do more harm than good in such type of fluid? So don't give IV fluids. But put a proviso to say, but if to be given, e.g., in context of augmentation, then half the dose of oxytocin and also half the fluid. So if you like augmenting using 500 ml of normal saline, you use 250 ml. And instead of giving, maybe you like giving 2.5, you give 1.25. The other option is to reduce the drop factor, because normally we give 20, 40, 60 drops per minute, every 30 minutes. And I hope we specify these dosages when you're in about. Don't just say augment and you go. Augment with oxytocin, 2.5 dashes, 500 ml of saline at 20, 40, 60 drops per minute, increased half hour. Should be very clear instruction to the midwife. Now, what we are saying here is that either instead of giving 20 drops, we'll be giving 10 drops. But instead of manipulating the drops, I think it's much easier to manipulate the dose. You have it, you also have the fluid. So in other words, you are giving it cautiously. Next is once active phase of labor is established, you open the what? The pantograph and monitor labor by it. Of course, this is standard. Then that is basically management of first stage. So you have to write clear instructions. Next, we are going to go to second stage. Between full cervical dilatation and delivery of the baby. So the first thing is ensure sterile field. Very important. Now, this is not even supposed to be put here because this is supposed to be all our standards in all our labor wards. I would be so happy if I can enter into a labor ward and I find a midwife is asking the patient, which is your preferred position for delivery? No, me, I want to be delivered while standing or while walking. Okay, that is possible. But you advise, no, I think lithotomy is good for you because you'll be able to see properly and this and that. Okay, that's fine. Next, you give instructions so that she only pushes in tandem with the contractions. But what else should you have done? Go and scrub, hand dry, double glove, swab the vulva, and drape the patient. Exactly what you do in theater is what you are supposed to do in the ward. Extremely important, more so for cardiac problem, because you can actually help take the infection on the valves, which are already diseased. So if she had endocarditis, it will then come back. Because don't forget that the uterus is a sterile environment, and you are basically helping him introduce infection through the hematogenous route. So here, I'm very, very particular. For a cardiac, you are going to see, I will make sure, if it means borrowing grapes from theater, I'll borrow them. But ideally, all units are supposed to have. Okay, then next is that shorten second stage. With what? With the forceps or vacuum. Of these two, the best is obstetric forceps. Because a vacuum requires maternal effort, despite being connected to electricity. a forceps does not require maternal effort, and that's why it's one of, in fact, it's my favorite form of instrumental delivery. So, even if somebody doesn't push, but you're just basing it on uterine contraction alone, you can actually deliver the baby using the obstetric forceps. And our preferred forceps is the Wrigley. Wrigley is the obstetric forceps. It's an outlet forceps. Wrigley. Okay. Okay, or if you don't have a Wrigley forceps. Now, why are we saying shortening? Because second stage takes how many minutes? Maybe 30 minutes. Because the cervix can be fully dilated, but the mother has got no edge to push. But you can feel that the station is below, maybe plus 2. So you can grab it with an instrument. But instead of you waiting and asking the mother to push, you don't need that. You just help get the baby out, so that she doesn't have any maternal edge to push. No wonder I'm saying that forceps are better. So you put one, they articulate, and if you know how to do it correctly, in the correct position, you can actually remove the baby very easily. Okay, now let me mention that one of the reasons I just did not mention it when we discussed hypertension. One of the indications for shortening second stage is in hypertensive crisis. A woman is in labor, second stage, and the blood pressure is 240 over 120. Do you know what will happen when you start telling her, push? She will develop a CVA. And I've seen it before. Just delivers the baby, the mouth goes one side. Because you've allowed now more pressure, more pain, and so on. So this is one of the indications for shortening the second stage. It's in a hypertensive situation, but this is another indication is in cardiac disease. Third stage. Number 1, do not use oxytocin or egometrin. Egometrin is contraindicated. So you have to write it in your delivery plan. Do not use egometrin. Yeah, anyway, it was during that time when you are using a lot of egometrin as well. But, or symptometrin, you can't use those type of drugs because of the cardiac disease. I can rub off this side. Then the next thing you write is that, and we are concluding, that you can go for lunch and enjoy our weekends. So I know the mind is not even need. Mine is that Muchinga garden. So do not use egometrin. Okay, or you write egometrin is contraindicated. Then next you say active management of third stage of labor. But we all know we always do active management, but you have to specify, you emphasize active management of third stage of labor, meaning I wait for a contraction or expedite the contraction. Once it comes, controlled contraction with the countertraction. The Andrews, I almost said Andrew Smith's, that's a method for bowel anastomosis. Andrews Brandit's maneuver, where you do this, right? Like you are pushing, so that there is no uterine invasion. Anyway, we all know this. And then remember, when the placenta comes closer, you twist the membranes to ensure complete separation. Having given oxytocin within a minute of delivery. Clear? So the arms tail is self-explanatory. Then, next, furosemide. So you can give even 60 milligram IV starts at this point. Why are we giving furosemide? It is to prevent what is called autotransfusion. Because it means all that blood which was in the placental bed, now that we've removed the placenta, we will have nowhere to go. It will go back into the maternal circulation, into the inferior vena cava, through the ovarian veins, the uterine veins, through that system into the vena cava. And from the vena cava, it will go to the heart. You know that the heart can be overwhelmed and the heart will just dilate. And that's part of the theories behind postpartum dilated cardiomyopathy. So to avoid such type of problems, you need to give furosemide so that you reduce the plasma volume, so that the blood which goes back to the heart is reduced. Clear? Then from there now we go to PPH prophylaxis. It's very dangerous to have a cardiac patient go into PPH because you're avoiding fluids, but somebody's bleeding. So what are you going to do? You give too much fluid, even wasn't the problem, so you'll be in a predicament. So make sure, no wonder this arm still becomes important and this PPH becomes important. Don't leave retained products of conception. So PPH prophylaxis, what are we saying? We are going to give TXA, 1 gram IV slow, start. What else? Misoprostol. 800. No, for prophylaxis, you can even use 600 microgram per rectal start. I then talked about oxytocin infusion. Why? Because I'm avoiding fluids. Then, finally, monitor vitals for PV bleeding, input, output, whatever, for the next 24 hours in HDO. Don't take the patient to the postnatal ward. Keep in that for the next 24 hours because the patient is still at risk. A lot of physiological changes are occurring, and after that, I will write now. Because I've formulated the delivery plan, Mulenga JRMO. I then come back on behalf of my consultant, Dr. Kasonde, secondary. So that's a delivery plan. It's not only in cardiac disease we do make delivery plans, but in placenta previa, in diabetes mellitus, sickle cell, or any other special condition. Why do we make delivery plans? It's because if there is an emergency, let's say there is the placenta previa med, and patient starts falling, those instructions are clear first for the nurse or midwife who is on duty. Do you think they will start waiting for a doctor? They'll say everything is written. Take to theater, do this, do that, do that. So even this delivery plan doesn't mean you have to start looking for what the other people wrote. That just shows you how important the plan is by putting it as the first page on your file. Now, I'll conclude by saying that it's not all patients that will require furosemide. It depends on the cardiac lesion. Because if it's aortic stenosis, avoid furosemide because of what I said. Once you drop the blood pressure, meaning you drop the preload, the afterload, you end up with the cardiac arrest. So you need to individualize your patients. But this is generally common delivery plan for all patients. But at postgraduate level, we'll go into specific lesions and see how to manage each of these one by one. But we shall not go into that. I think we can end here. Okay. So, cardiac disease, our main aim is to aim for vaginal delivery. We avoid cesarean section at all costs, unless there's an obstetric indication. For instance, it's a 2 previous cesarean section, it's a transverse line, fetal distress, or just failed augmentation, failed induction, or the baby is just too big, both clinically or there must be an obstetric, not necessarily doing it outrightly as the best mode of delivery. Why? Cardiac disease is dangerous for anesthesia. Don't use spinal anesthesia for cardiac disease. Make sure it's done under general anesthesia. So the pre-anesthetic assessment is very important, and equally you need to make sure that when you are in theater, you're not just seated and saying, "Sister, call me when I'm ready." You just hear a voice, "Doctor, go and scrub." A responsible surgeon, clinician, ML or MO, whoever does operations, will be present throughout. We'll do a surgical checklist. And we will ask the anesthetist, "What is your mode of anesthesia?" If they tell you that, as usual, we want to give spinal, say, no. I think on the obstetric point of view, spinal is not appropriate. Give general anesthesia. If they are not comfortable, they can equally consult through their hierarchy systems up to whoever can advise what type of general anesthesia to be given. The same reason I was worried about epidural is the same reason I'm worried about spinal. So, colleagues, this is extremely important. Take interest even in the other fields of theatre. What's happening to the scrub nurse? What's happening to the midwife? What's happening to the anesthetist? So that we all agree and come up with a common thing. I'm mentioning this because we've had cardiac arrests. Patient was just okay, well managed, sent for elective cesarean section, and just at the giving of spinal, as you try to make the patient sleep, that's the end of the patient. I've seen that. Just like that. The doctor is coming from scrubbing, finds that they're doing CPR. So avoid that by just being careful, by making sure that cesarean section, first of all, is avoided. But if you cannot avoid it, then an experienced anesthetist should be present and make sure, as the clinician with this background information, you suggest to them. If somebody insists to say, "No, me, I still want to give spine," then you reserve the right to say, "I'm not comfortable then to operate on this patient." You reserve the right because you know what is likely to happen if you compromise on that. Thank you.